Alright, so just moving right along. Cholelithiasis. If you were to break this word down, cholelithiasis, this means biliary or gallbladder related, and stones. Now, these stones can be occurring anywhere within the hepatobiliary system, common hepatic, cystic duct, gallbladder, common bile duct, and it can even occur retrograde or anterograde, and it can also get stuck in the pancreas. So, when we start thinking about cholelithiasis, 10% of those people around you have gallstones. 25% of these people will become symptomatic within 25 years. And by symptoms, we typically mean pain, nausea, vomiting. And so when we start combining these words together, symptomatic cholelithiasis, these are people that are coming in with maybe right upper quadrant pain, it's radiating to the scapula, the right shoulder, and they're having stones on diagnostic workup. Sometimes we'll interchange the terms chronic cholecystitis with symptomatic cholelithiasis. And how I think about this is that the chronic cholecystitis component means an excessive amount or multiple amounts of symptomatic cholelithiasis attacks. Now, the stone dissolution techniques, the interventional radiology techniques, the medical therapy is rarely used and it is not really successful, so I would be avoiding doing this. The pathophysiology for cholelithiasis could be a combination of supersaturated bile, where it's just getting really thick, viscous. Could also be the gallbladder bile concentration, the crystal formation, and or the dysmotility or dyskinesia. What ends up happening, if I were to draw this out, caveat, I'm not an artist. When you have food that hits the stomach, this signals to the liver to make bile. Well, there's already bile stored within the gallbladder, and the gallbladder will clench down and squeeze out this bile. But what happens if there are gallstones within the gallbladder? Well, these gallstones can get stuck within the cystic duct, and you have pain, 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 and these stones fall away. Should these stones remain in place and not fall back, that's when you start converting a symptomatic cholelithiasis to acute cholecystitis. When you see these people in clinic or maybe in the ER or whatever setting it might be, like I said, the symptoms that are most classic for symptomatic cholelithiasis are epigastric or right upper quadrant pain, and this pain can radiate to the scapular right shoulder blade. And usually this is postprandial. And what I mean by postprandial is that after eating, you can have pain. Now, what I like to differentiate in my mind when I talk with patients, I like them to do a dietary log. So if we have pain on this axis and the time or chronicity over here on the bottom axis, for GERD, after they've eaten something, it goes down. And if you're thinking GERD, this hits the stomach. So shortly thereafter, seconds to minutes later, they're going to have pain, and the pain usually goes away. However, for gallbladder related issues or biliary colic, on this timeline, they have a crescendo pain that increases, and can last hours and hours and hours. So, yes, you can have postprandial pain, but this can last several hours. And this is usually accompanied maybe by some nausea, vomiting, bloating. Now, what we like to memorize for tests and so forth, and this isn't always true in real life, but you consider female, fat, fertile, over 40. You should also consider this diagnosis for patients that are on TPN and also with an ileal resection because of the enterohepatic circulation and decreased absorption of bile salts. So, how would you diagnose this? Well, could you get an x-ray? You could, but you really won't see these stones. 10% of these stones are going to be radio opaque. However, if you look on this x-ray slide right here, there's indeed a gallstone right up there on the right upper quadrant. Now, the way to diagnose gallstones or the gold standard would be to use an ultrasound. Now, these ultrasounds have acoustic wavelengths, and these wavelengths or the ultrasonic waves are going through tissue, going from anterior to posterior. Now, as you can see in this image right here, you have the gallbladder. and also the gallstone. When these ultrasonic waves go through the gallstones, however, sometimes you can see posterior acoustic shadowing. What does that mean? Well, if the probe is up here anteriorly and you have this shadowing, it's posterior. And this is due to the hyperechogenicity of the stone, meaning that this is kind of a thick substance or a thick material for the wavelengths to go through. Now, a parallel right here is also when you look at breast cancer, certain things can help perk your ears a little bit to think this is breast cancer or more of a malignant breast process. And one of those things read out on radiology would be posterior acoustic shadowing. But don't think that this is malignant for a gallstone. This is simply saying that the tissue is thick, that the ultrasonic waves are going through. Also, what you can see are that these gallstones can be mobile and they can shift around, which would be different than polyps, because polyps would not be dependent on the position of the probe and the position of the body. They would be dangling almost like stalactites in a cave. Here's another image of an ultrasound. Again, your probe is sitting up here. You have a little bit of shadowing back here, but you can see the gallstones and also sludge. And for all intents and purposes, sludge equals cholelithiasis, which equals gallstones. The gallbladder wall in this is not thickened, it's less than 4 millimeters, and I do not see pericholecystic fluid. There is going to be fat, that's typical, but not pericholecystic fluid. Would we be able to see this on CT scan? Sometimes, but like I said, 10% are radio opaque. But this is sometimes what you can see on a CT scan. And I would say this is quite a large gallbladder. So the treatment for gallstones, if it's asymptomatic, is to do nothing. You should observe. But like I mentioned, 25% will have symptoms within 25 years. The other statistic to keep in mind is that approximately 85% of the patients that have gallstones do not have any symptoms currently. But should you consider a prophylactic cholecystectomy? Well, possibly. If you have a patient that has sickle cell, and maybe they've had an attack in the past or another hemolytic anemia, you should consider a prophylactic cholecystectomy if they have stones and the hemolytic anemia. You should also consider it with a large stone or an increased cancer risk, as well as bariatric surgery history, such as a Roux-en-Y gastric bypass. If the patient has symptomatic, uncomplicated cholelithiasis, the treatment would be an elective cholecystectomy. So, how would you perform a minimally invasive cholecystectomy? Well, preoperatively, you're going to be giving the patient antibiotics, and you want to sometimes consider GI coverage as well. And typically, you can give metronidazole, ceftriaxone, you can give Zosyn, but the patient's going to be positioned supine. They're going to be receiving general endotracheal anesthesia. One arm's going to be out for the anesthesia team. You're also going to be placing this patient on a footboard and also placing double straps because they're not going to be supine for the whole case. You're going to be going reverse Trendelenburg and also rotating to the patient's left in order to get the viscera and other abdominal content out of the way. Every time that you see these patients in clinic or preoperatively, and for really any minimally invasive operation, you should be considering the possibility of an open operation. Specifically for a gallbladder surgery, you should always mention the possibility of an intraoperative cholangiogram because this exposes the patient to radiation, and also the possibility of a common bile duct exploration. I want to briefly go over intraoperative cholangiogram, or otherwise known as an IOC. Intraop meaning during your operation, cholangio, so biliary system or gallbladder, gram is X-ray. So what you'd be doing during this operation is if you have a gallbladder right here, common hepatic, common bile right there, you'd be making a transverse ductotomy and make sure it's going to be less than 50%, or you're going to have some type of endoloop or something to help close this. But once you've made this ductotomy or cystic ductotomy, you'd be then placing a cholangiocatheter into that ductotomy and shooting contrast. When would you be considering doing this? Well, if you can't dissect out the critical view of safety, if you have concern for the anatomy, maybe it's hostile, or maybe you have a concern for a biliary tract injury. Once you have this placement of the cholangiogram catheter within that cystic duct, then you'd be shooting your fluoroscopy or your x-ray. So in this picture right here, this is a normal intraoperative cholangiogram. You have your instrument, your laparoscopic instrument right here. You can actually see the port right there as well. But this catheter is placed about right here, and you're shooting contrast down into that catheter. And the contrast is filling down the cystic duct number 3, into the common bile duct or number 2, and also retrograde into the common hepatic duct. And then this spills into the duodenum. There is no filling defect, there is no meniscus sign, there's nothing demonstrating choledocho or any other concern. Thus, I would say this is, once again, a normal intraoperative cholangiogram. And these are the steps right here. The steps for this operation would be first getting intra-abdominal access, thereafter getting traction. And for this case, you can see that this is a conventional laparoscopic case where you have your laparoscopic instrument grasping the fundus of the gallbladder and retracting it over the liver towards the right shoulder blade. Next, once you've gotten the traction in place, you will then be releasing the peritoneum both medially and laterally. After you've done that, you'll then be concentrating on the critical view of safety. And what is the critical view of safety? How I like to summarize this and to keep this memorized in my head is that you should be considering the liver, the gallbladder, and the ductal structures. Here's a representation of the critical view of safety. You have two and only two tubular structures going into the gallbladder. Number two, you have the bottom third of the gallbladder dissected out, included of all fibrofatty tissue. And number three, you have the hepatocystic triangle dissected out, meaning your liver, hepato, cystic gallbladder, and then also the cystic artery. You can also call the hepatocystic triangle the triangle of Callot. Once you've achieved a critical view of safety, you can then clip your cystic duct and the cystic artery, and thereafter take the gallbladder off the liver bed and close your ports. A final note on the cholelithiasis chapter would be if a patient is pregnant and they have symptomatic cholelithiasis, not asymptomatic, symptomatic, you should also consider an elective cholecystectomy.